we're going to talk about the EFAST exam today and how it's not just for the emergency department. If I can get my slides to advance. There we go. So we're going to briefly talk about the history of the FAST and the EFAST, go through the exam and where to find pathology on the exam, and then do a literature dive on the utility of the FAST exam in different settings, and then some alternative uses for the exam as well. All right. Any good medical talk starts off with a patient case. So here's our first one. This is an 8-year-old female who's struck by a motor vehicle. On her primary survey, she's tachycardic, but she's normotensive without hypoxia. On secondary survey, there's some chest and abdominal wall bruising and tenderness. CT scan done in the ED showed a grade 2 hepatic laceration and a small pneumo. And of course, for multiple reasons, there was a delayed admission to the PICU. Upon arrival to the PICU, patient has new hypotension, worsening tachycardia, and new hypoxia. So you grab your handy dandy ultrasound, and this is what you see. I'll give you a couple of seconds. So in this image over here is the right upper quadrant view, and you can see that there's some fluid right outside of where the tip of the liver is over here. Not an alarming amount of fluid, plus we already knew that this patient had a grade 2 splenic lac, so not likely not the etiology of this new instability. But if you look at this image over here on the right, this is pathognomonic for pneumothorax, so that's a lung point, and this is found at the posterior axillary line. So in your supine patient, that indicates that this is a massive pneumothorax, so likely in tension. For a second patient, this is a 15-year-old male who had 3 gunshot wounds to the box. So for the uninitiated, the box is basically anywhere where you can have a penetrating injury that it could hit the thoracic cavity, the pericardial cavity, and or the abdominal cavity. So this patient was taken to the OR with surgery for operative exploration, and they found a lung injury, a lacerated pericardium, and a diaphragmatic injury. 1 hour post-op in the PICU, there's new hypotension and new hypoxia. So you grab your ultrasound, and I'll give you a few seconds. So in this image on the left here, this is in the left upper quadrant. So you have spleen and kidney. There are no obvious signs of free fluid in this view. And then here on the right, we have good lung sliding on both sides, indicating this is likely not a tension pneumothorax causing this new instability. And then on these images, I'll start on the right here. So this is the heart with no signs of pericardial effusion. But here on the left, this is in the right upper quadrant view, and you can see there's a positive spine sign. So there's fluid in that hemithorax right there as well. So potentially a massive hemothorax being the cause of this patient's instability. All right, so brief history. So the first studies that looked at integrating ultrasound into the bedside in the emergency department was back in the 1970s, specifically looking for splenic injuries for blunt trauma. The FAST as we know it was first described in the early 1990s, and then a few years later, the thoracic views were added to the FAST exam, and that was called the extended FAST or the EFAST exam. That's it for history, I promise. The indications for and the goals of an EFAST exam in trauma. EFAST can be done for blunt or for penetrating injury, but the exact indications are subjective. Does it need to go? Does it need to be done for a, a stable blunt trauma patient or stable stable penetrating trauma patients? Do they need to get a fast as well, or could they just go to the operating room? The goal of the EFAST is to find the fluid. Finding the fluid will eventually indicate needs for further imaging, and that could be fluid in the peritoneal space, in the pleural space, or in the pericardial space. When we have a patient who's being transported to us from another hospital, it could be used to identify the risks of stability prior to transport, either between hospitals or between the emergency department and other departments of the hospital. A very intelligent mentor once said that all death begins in radiology. And for the generally unstable patient, to find the source of that instability. So for the optimal EFAST exam, it's supposed to use clips and not stills. This will allow you to fan through an area. There may be fluid evident in only one plane of view. When you see fluid, look towards the edges. So fluid where it's not supposed to be should be sharp. You're dissecting down fascial planes and in potential spaces. Fluid where it is supposed to be tends to be rounded. So think the bladder, the gallbladder, cysts, things like that. You can perform the abdominal part of the EFAST with either the curvilinear or the phased array probe. One benefit of the phased array probe is that it is a smaller footprint, so it can get between the ribs a little bit better. I personally don't like the image quality of the phased array, so I almost exclusively will use the curvilinear probe. When you're doing the thoracic views, you can flip it over to a linear probe, or you can keep it the curvilinear or the phased array. Just make sure that your depth is very, very shallow. And this is the basic EFAST exam. So we have used in the right upper quadrant, in the left upper quadrant, in the suprapubic area for free fluid in the abdomen, the subxiphoid or the subcostal view for looking for fluid around the heart, and then the two thoracic views. It doesn't matter in particular what order you do these in, just do them consistently the same way so that you don't miss anything. So we're going to start where I typically start, which is in the right upper quadrant. So for this view, you want to orient your probe longitudinally with the indicator going towards the head, starting at about the mid-axillary line with the bottom of your probe at the costal margin. This image on the right shows the placement of the probe, and then approximately what your view is looking like on the right there with the illustrated anatomy. And then superimposing the sonoanatomy on top of that. So in the near field here, this organ that's kind of the middle gray that has a bunch of tubes going through it. This is the liver. Tucked right underneath of that is the kidney, so the typical hyperechoic medulla and hypoechoic cortex. The Morrison's pouch, that potential space, that reflection of peritoneum goes in between those two organs right there. And then directly back behind where the kidney and the psoas muscle are, this is the spine. This bright line that's right on top of where the liver is, that's the diaphragm. Now, the places we're going to be looking for free fluid in this view are number one in Morrison's pouch. So again, that potential space between the kidney and and the liver. Number 2 in the subdiaphragmatic space, so there's another reflection of peritoneum that separates the diaphragm and the liver. Number 3 is at the tip of the liver. This is contiguous with the right paracolic gutter. So if there's any fluid that is settling into the right paracolic gutter, it'll directly abut where the tip of the liver is. And then last, in the thoracic space, right above where the diaphragm is. In this image, you can see that in certain planes, especially at the beginning, it doesn't appear that there's any free fluid there. But as that area is scanned through, you can clearly see fluid that is either subcapsular or in Morrison's pouch, as well as free fluid at the tip of the liver. This image here illustrates the spine sign, which is indicative of fluid in the hemithoracic space. In normal upper quadrant views, you can only see the lateral aspects of the vertebral bodies as it comes up to where the diaphragm is right here. The reason is because there should be air-filled lung that is directly on the other side of that diaphragm, and air obscures ultrasound beam, so you shouldn't be able to see anything past it. But now imagine there's fluid in that thoracic space and it's taking that air-filled lung and it's pushing it out of the way. And now you're able to see through that area, and you can see the spine up above where the diaphragm is. So if you see spine up above the diaphragm, that's a positive spine sign. And if that area looks black, then it's fluid. There are other conditions other than trauma that you can see a positive spine sign in. So for instance, if you had a kiddo with nephrotic syndrome whose abdomen was less than 1 and they had a pleural effusion, it would look the same. If there was a child who was having cough, difficulty breathing, fever with consolidation on chest X-ray, a pneumonic effusion would look the same. Because when we have to take our put our radiology hats on and clinically correlate to what we're seeing in front of us. So from the right upper quadrant view, I go next to the left upper quadrant view. The optimal position for this is up a little bit higher. Indicator is still towards the head. You want to go a little bit farther up and a little bit farther back than you were in the right upper quadrant view, because the spleen is not as good as the liver. In general, you need to get your knuckles on the bed and stay perpendicular to the left flank to be able to get good visualization. The Netter image on the right isn't great. It's the best approximation I could find to the orientation of the organs that we're looking at. And then the superimposed sonoanatomy. So right here, the middle gray without as many tubes running through it as the liver. This is the spleen, and then the kidney as well. So similar to the right upper quadrant and the left upper quadrant, there are 4 different places we're going to be looking for fluid. So number 1 is going to be in the subdiaphragmatic space. Number 2 is at the tip of the spleen, so that's contiguous with the left paracolic gutter. 3 is in the splenorenal recess. It's said that the splenorenal ligament is a very strong ligament without a lot of give in it, so you're less likely to see fluid between those 2 organs than you will on the right side. And then also looking at the thoracic space. And of course, after I say that, this is a direct example of fluid in that splenorenal space, right here in between those 2 organs. All right, so after the left upper, I then move on to the suprapubic view. So these are views that you'll obtain in both the transverse and longitudinal views. It's best to start right above the pubic symphysis. I usually start in transverse. Now, obviously, the anatomy that you're going to see is going to change depending on whether there's a uterus present or not. So in a pelvis with a uterus present, in the near field, you're going to see the bladder. Directly behind that, the uterus. There's a potential space right behind that called the pouch of Douglas. And and then the rectum is right behind that. So the place that you're going to see fluid collect is in this pouch of Douglas, so between the uterus and the rectum. If you get enough fluid, sometimes you can see fluid anteriorly to the fundus of the uterus, but you'll never see fluid going between the bladder and the uterus because they are uh, uh, they're both covered with the same peritoneal coverings. So this is what that's going to look like. So on this pelvis with a uterus and the transverse, we have bladder, we have the uterus right there, and then this is the pouch of Douglas directly behind that. We can see a little bit of fluid kind of creeping out the side of the bladder over here, but notice there's no free fluid between the bladder and the uterus. This over here on the right side, this is a special situation called a TIE fighter sign, referring to the Imperial Starfighter ship from Star Wars. This is one of those instances where there is so much free fluid in the abdomen that is both anterior and posterior to where the uterus is, and then the suspensory ligaments of the uterus are holding it up at the very edge of the image, not here, but right there. That's where the bladder is. So this is not bladder, it's coming right at the end of the image right there. So turning our probe now 90 degrees with indicator going towards the head. This is what the pelvis with the uterus is going to look like. So anteriorly, you're going to have the bladder, have the vagina and the uterus coming in this way, and then your potential space, your pouch of Douglas right behind it, and then rectum, and you can see how that tracks here with this sono image. And these are some examples of free fluid in the pelvis in these patients. So again, fluid tracking down into Morrison's pouch here behind the uterus. This is another good example how you're not going to see fluid dissecting down in between the bladder and the uterus. There's a lot of fluid, but it's all superior to the bladder. And if you were scanning this patient in transverse, then you're going to see this pocket of fluid towards the fundus. And then as you go inferiorly, then you'll pick up the dome of the bladder. That is a very common false negative finding when you have that much fluid in the pelvis for it to be misconstrued as the bladder. All right, so in the pelvis without a uterus, anteriorly you have the bladder and the rectum, and then this is the potential space in between those, the rectovesicular pouch. And here you can see a couple examples of fluid in these pelvises. This is a small amount of fluid right there, so you can see these aren't rounded edges, these are sharp edges there, which tells you that fluid's not supposed to be there. This is more subtle, and this is not. So massive amount of fluid in this pelvis, and this person's actually going from transverse into longitudinal. So looking at that pelvis longitudinally now, so in the near field, you have this triangular bladder with the rectum directly behind it, and then the rectovesicular pouch, that potential space should be between the two of them. And we can see in this image the free fluid that is dissecting down directly behind the bladder in front of where the rectum is. All right, so moving on from the pelvis is the subxiphoid view or the subcostal view. And this one, we're basically looking at the heart upside down and backwards. This is even more limited than point of care echoes are. So we're not necessarily looking for function. We just want to see are there signs of fluid around the heart in the pericardial sac, with this being an example of that. So liver in the near field, bright pericardium, and then this global fluid collection around the heart there. So in the setting of trauma, that is presumed to be blood. Now on to the thoracic views. We'll be looking for signs of pneumothorax here with your probe in a longitudinal orientation, with the indicator going towards the head. You want to try to look um, where it's recommended in children to needle decompress in the setting of attention pneumothorax, so second intercostal space midclavicular line. And this is what you should see. So with your probe straddling a rib space, you should have a rib with its hyperechoic cortex and then shadowing behind it, and then another rib, and then the bright line that connects the bottom of those two, that's the pleural line. So that's where the visceral and parietal pleura are touching each other and should be sliding back and forth with the intercostal muscle just superficial to that. So focusing on that pleural line, this is what we're looking for. So we're looking for lung sliding. So this is often described as ants marching on a log. And it took me a while to see it, but then I could eventually see it. But you should see some movement at that pleural line. If you're ever looking at it and you're not sure, one thing you could do is to turn down your gain, make everything a little bit darker. It tends to make the pleural line stand out a little bit more. But if you do that and you still can't tell, maybe there's sliding, maybe there's not, then we can use what's called M mode or motion mode. So in M mode, if you hit the button once, it's going to drop this line, and then you hit the button one more time, and it's going to make a graph for you. And this graph represents what are the light and dark spots on that line happening over time. So here, the x-axis is time, and the y-axis is depth. What this represents here is what's moving and what's not moving. So areas where you're not seeing any movement at all, those are going to be straight lines across because things shouldn't be changing. So anything superficial to that pleural line, so the intercostal muscle, the pectoral muscle, should not be changing very much at all as the patient's breathing in and out. But everything deep to that pleural line, the lung should be moving back and forth if it's fully inflated. And so you get this more kind of granular appearance here. And this is what's called the seashore sign. So you got the sand and then you got the waves here. On the left, this is not a still image. This is a movie. This is a clip. So looking at the pleural line right here, you can see, hey, there's really no movement there at all that I can see. So if you're still not sure and you augment your gain and you still can't tell, M mode can be our friend again in this instance. So if you hit the M mode button once, line comes down, hit it one more time, and the graph comes into view. Compared to that seashore sign, you can see that there are straight lines here all the way across, which means, hey, there's nothing changing as this patient is trying to breathe in and out, so that visceral and parietal pleura are not touching each other. And so this would be indicative of a lack of lung sliding. So this is also called the barcode sign. Now, a lack of lung sliding is highly suggestive of a pneumothorax, but it's not pathognomonic for a pneumothorax. This finding here is pathognomonic for a pneumothorax. So as we can see over time on the right side of this image, there's lung sliding that seems like it's coming in and out of view. But on the left side, there is no lung sliding here at all. So what you found is what's called the lung point or the leading edge of the pneumothorax. So every time the patient breathes in, their lung is expanding some, and so that area of lung sliding creeps more into your view as they breathe out. It retreats from that area of your view. Now, not only have you diagnosed uh, a pneumothorax, but where you find this also gives you a clue as to how large the pneumothorax is. So if typically you would start at that second intercostal space midclavicular line, and no, do I see sliding there? Yes or no? Um, if if they're sliding there, that's great. There's no clinically significant pneumothorax. If there's a lung point right where you're looking, it is likely a small pneumothorax. Because remember, air rises, water falls. If I were to look at that same second intercostal space midclavicular line and I see no lung sliding, I'm going to start to track inferiorly and laterally with the goal of being in the axilla, trying to find where this lung point is. So the farther back, farther posteriorly I find this lung point in the supine patient, the larger the pneumothorax is. All right, so now that we've talked about the EFAST and what it can do, it's important to talk about things that it can't do. So first, it's not great at picking up every intra-abdominal injury, namely hollow viscous injuries, diaphragmatic injuries, retroperitoneal injuries, and those injuries that are contained within a solid organ where there's no seepage into the abdominal cavity. For those specific kinds of injuries, there's contrast enhanced ultrasound where there's a lot of studies going on about that right now, but hasn't quite gone into the mainstream yet. The next limitation is what is the minimum threshold of free fluid that needs to be present in order to be detected by ultrasound? In this study back in 2003, they had adults undergoing diagnostic peritoneal lavages, which thankfully we do not do anymore, in trauma evaluation. And they would instill aliquots of saline into the abdomen while they were looking in the suprapubic view for free fluid. And the median amount of fluid that was needed to have a positive suprapubic view was about 100 cc's. Granted, that was technology that is now about 20 years old, and our ultrasounds are getting better and better at finding smaller and smaller amount of fluids. I doubt we'll see a similar study to this because we're thankfully not doing DPLs anymore. On the flip side of that, how if we see free fluid, how much of that can be normal? Traditional teaching was that we should only see free pelvic fluid in postmenarchal females. Well, again, as our technology is getting better and better, we are seeing more and more trace pelvic free fluid in males and in premenarchal females. So Holmes back in 2000 did this study looking at kids with blunt abdominal trauma who had free fluid on CT, so not an ultrasound, but who had a normal abdominal exam and no altered mental status, so you could trust their exam. They had a very low incidence of intra-abdominal injury. And then in 2009, Cristiano and his group looked for isolated pelvic free fluid on CT scans with no associated injury, and they found that about 14% of the scans had some pelvic free fluid. And then Simonovsky in 2011 looked with ultrasound at 200 asymptomatic pediatric patients, where about 6% of of all the scans had some free fluid, all of which were measuring less than 1 cc. So what does the literature say about the EFAST in our patient population? There's a lot of adult literature, but what does it say about pediatrics? So Holmes, back in 2017, found that in the stable blunt abdominal trauma patient, FAST is not very helpful. It's not particularly indicative of a clinically significant intra-abdominal injury. Long in their group in 2021 found that it is helpful with the unstable patient, especially the undifferentiated unstable patient. It was able to predict that need for early surgical treatment, and the longer after the injury, the greater the accuracy of that scan was. Which begs the question, what about serial EFAST exams? So back in 2004 at an adult trauma center in Miami, they had their initial scan upon patient arrival and then did a second scan at some interval after that within the first 24 hours. On the second scan, the sensitivity and the negative predictive value improved with that delayed scan, and they found that no patient with a negative EFAST at 4 hours developed clinically significant hemiperitoneum. So it sounds pretty promising for doing serial exams, doing delayed exams, but there's no specific literature in kids. There was this one case report back in 2000 that they had one kid that they were able to do serial FAST exams on who had an injury in the setting of persistent tachycardia that went on to do further imaging, and they detected a splenic laceration. So still a little wanting in the realm of pediatric literature. So maybe you're not seeing acute trauma, but there are aspects of the EFAST exam that can be utilized in other ways. So one of the first is something called the RUSH exam, the rapid ultrasound for shock and hypotension. So first described about 20 years ago. It was developed as a way to evaluate the undifferentiated, hemodynamically unstable patient. The components of the RUSH exam are that can be remembered with the acronym HIMAP. So H stands for heart, so looking for cardiac activity, for qualitative LV systolic function, for signs of fluid around the heart, and signs of tamponade, looking at the IVC, so looking at the tank, checking for signs of hypovolemia, looking at Morrison's pouch. The M in Morrison's pouch is more to be a placeholder for the rest of the FAST exam, so looking at the abdomen for free fluid. This was initially described in adults, so looking at the aorta, mainly for looking at ruptured AAAs and aortic dissections, and then pneumothorax, looking for tension pneumothorax. So there's no pediatric data, but in adults in this meta-analysis had pretty good sensitivity and specificity for detecting where the instability in these patients was coming from. And finally, components of the EFAST exam can be used in evaluation of other conditions, like in the presence of ascites, like in this image on the right. The thoracic portion that can be used to detect pneumothorax or pleural fusions in other clinical settings. obviously the cardiac portion, looking for pericardial effusions. And then the transverse and longitudinal suprapubic views are used in determination of bladder volume. So in conclusion, the EFAST is used to check for abdominal free fluid, the pericardial fluid, pleural fluid, and then signs of pneumothorax. They are best in the unstable trauma patient. Serial exams have been found to be helpful in adults, but no data in kids. And an EFAST exam is a big part of the rush exam. So that rapid ultrasound for shock and hypotension, your approach to the undifferentiated unstable patient. And so a couple questions. Question one, and which of these patients would the EFAST to be most helpful to determine next steps in management? I'll give you a few minutes to read through those. So in these four clinical scenarios, if we go through them one by one, this 8-year-old status post MVC, stable, so likely not going to be helpful. This 17-year-old female has a stab wound to the left upper extremity and tachycardia. If that is the only injury, then hypovolemia from hemorrhage would be the only reason why this patient would be unstable. Coming to answer choice C here, so this 11-year-old male, pedestrian versus auto, who is tachycardic and who is hypotensive. So this is the patient that EFAST would be most helpful for, because there could be injuries anywhere on the torso. And then for this patient, this 13-year-old who was impaled by some rebar in the right lower quadrant with normal vital signs, we know it's a penetrating injury. Their FAST is likely going to be positive, but again, they're stable, so not very helpful. So for question two, most likely location of free fluid in the female pelvis and the pelvis with the in the presence of a uterus would be where? And that should be the Boucher Douglas. All right, last question. The pathognomonic sign for pneumothorax should be the lung point. So you found the leading edge of the pneumothorax. The most important question, true or false, the 2018 Clemson Tiger football team is the greatest college football team of the playoff era. And that answer is true. Go Tigers. What questions can I answer for you?